The reason for that is that there has been a lot of lack of awareness about pediatric endocrine disorders. So we started off with workshops and practical courses which were held across the country. Then we realized that it was very difficult to cover large areas because it is so much logistically difficult. So we started off with social media, particularly with YouTube. And then we started our fellowship program. Now we have got, today we have now got around 10th fellow. Dr. Dhwani has joined as well. So we have got now 10th fellow in our system who has joined the CDR program. Then we started off with our online courses and then finally textbooks and mobile applications. So we have tried to take forward in terms of making it easy and easily available and accessible in that regards. We have conducted a number of courses. The first practical pediatric endocrine course actually happened 10 years ago. So since then, we have got a lot of physical programs, but we also now have a lot of online programs which are there. So this is the third online program which we are doing because this provides a much wider access across the globe in that regards. We have our YouTube channel, which has got large number of videos which provide information about every aspect of pediatric endocrinology. There's also an online course which covers various aspects using validated tools. And we have got special courses, including the pediatric endocrinology for fellows, for postgraduates, fellowship in pediatric endocrinology, and a number of programs which are available online, which you can access through our website. We also run routine, regular postgraduate lecture series along with grand rounds using specific cases. So all these are concised in around 8 hours. These ones will run a long time and cover the entirety in that perspectives. And we have got publications which you can access and our mobile application, which will also showcase how it helps in terms of making point of care assessment and diagnosis possible. We are in the process of developing and probably will launch soon about our personalized intelligent EMR, which will allow our overall aspect of care using minimal inputs. Patients will get detailed output with regards to the likely diagnosis, likely evaluation and management. This will make connected clinics through using the e-system, making it much easier to whatever has been learned to implement in that regard. So recently, we have got a lot of programs. People have joined the fellowship program and the diploma program as well. So coming specifically on this International Practical Pediatric Endocrine course, we have got this 2-day program. First day is dedicated today on office endocrinology. We'll be covering growth, thyroid, puberty, and DSD. And tomorrow, we're going to cover the endocrine emergencies, mainly calcium, electrolyte decay, and hypoglycemia. So 8 modules. Sir Vijay Jaiswal, Dr. Anurag Katiyar, Dr. Bifina, and Dr. Riddhi, and Dr. Sayan will help me out. And we'll try to cover the various aspects about growth in the next 1 hour or so. So why is growth important? So we have this 12-year-old girl, height is 132 centimeters, weight is 20 kgs. Now, when we evaluate this child, the key question is 80% will be physiological and approximately 10% will have a pathology. The question is which child is physiological and which is pathological. We do not want unnecessary investigations in this group, while we do not want to miss this. And this is what we're going to talk about over the next 40 minutes or so in that regards. So when we say growth failure, first of all, we need to understand that it is either physiological, which basically means either constitutional delay of puberty and growth or familial, or pathological. Then pathological means a problem which is intrinsic to the growth plate, like small for gestational age, syndromic causes, skeletal dysplasia. And when we talk about secondary, it could be nutritional or endocrine. So these are the basic parameters. So there are 3 questions that a pediatrician has to answer when evaluating a child with short stature. Is it really short stature? Now, for that, we obviously will talk about specific cutoffs and criteria. Next question, is it physiological and pathological? And for that, we'll talk about 2 specific criteria. So if your height standard deviation score is less than -2, it basically means you are short. That answer is easy. Next question is, what is CDGP? So for CDGP, we use a cutoff of height for the bone age. So if the height is less for the bone age, it is not CDGP. If the height is less for the family, it is not familial short stature. So just looking at clinical parameters, you will identify this. We'll go a bit about that. Then pathological cause, is it primary or secondary? Look specifically for syndromic features, look for body proportions, you will get that. Then you have nutritional or endocrine. So we try to look at specific objective evidences to say what will be an appropriate cutoff in that perspective. So what we found that as the height standard deviation score goes down, the chance of pathology increases. So below -2 standard deviation or more than -2, only 2 to 3% will have a pathological cause. -2 to -3, around 40-50% will have, and less than -3, you will have around 80% pathology. So if somebody is less than -2, worry, but less than -3, don't wait. Immediate evaluation is required, and this is what we will use in our algorithm. So anybody who is very short, height is below the first percentile or third -3 standard deviation score, short or not growing, height is between first to third centile, or -2 to -3 standard deviation score, and a low growth velocity, and somebody who is not growing at all, crossing 2 percentile lines between the age of 2 years and puberty. Now, this is important. Between the age of 2 years and puberty is something you need to evaluate, and we'll talk about how that is relevant from that perspective. So we'll start with the first case. Dr. Sayan, please come up and start the discussion from there. Let me just check if Dr. Anurag is there. So we have Dr. Anurag Katiyar, who has also joined us. So Dr. Sayan, you can start off with the first case.
Thank you, sir. So welcome to all, and we'll start off with the cases regarding growth. And the first case is that of a 12-year-old girl who presented to us with complaints of short stature. She had a height of 132 centimeter, weight of 28 kg. Her father's and mother's height are presented here. So Dr. Vijay, is the child short?
Thank you, Dr. Sayan. So before coming to any diagnosis regarding short stature, we have to first see the various parameters, that what is the height is, what is the weight is, and how the child is doing in terms of mid-parental expectation. So I would like to see the various information that what are the various parameters, whether she is fulfilling that criteria to have a normal. So so at present you have given me what is the absolute status of the child in terms of height. Next, I would like to see that what are the various parameters in terms of centile. So we have to see on the basis of that at what centile this actually girl is there. If there is any height standard deviation, what are the parental expectations? So unless and until we are not going to take the parental height, and then nothing is there in terms of absolute. So there will be always a target range. So target height range will be there. And we have to see the corrected SDS score, that is height SDS score, and in that particular girl, and whether there is any nutritional effect on the height or this is endocrinal problem, we have to see. So the most affected parameter, whether the height is or weight is in according to chronological age, and of course height standard deviation score and BMI standard deviation score to be taken in account. So I would like to plot this child on growth chart.
So thank you, sir, for telling us the basics of a growth chart. And sir, as you just asked, I have plotted the child's growth on the growth chart, and this is what we found.
Yes. So by this information at present, what we can infer that this child, this girl is looking on the lower centile, that is just below the third centile. So you can say that this info, we can say that she is a bit short for the population. But whether this is a pathological short stature, we have to take the account of parental height, mid-parental height. So I would like to see that what is the mid-parental height.
I have plotted the mid-parental height, sir.
Yes, yes.
Yeah, so this is the chart.
So yes, so now we can see that with this individualized chart for the family, you can see that at present the height is in between the mid-parental height expectation. So for me, this is again, we can see here that what are the affected parameters in terms of what is the height is and what is weight is.
So height and weight is around 9 years.
Yes. So if height is as well as weight is both are at the same pace, that there is no wasting. So it means that this is a normal girl child, and I would like to see in further that in the coming 6 months or 1 year, what is the growth velocity of the child. So yes, so this is a case of familial short stature.
Thank you, sir, for this very important point, that even if a child is thought to be of a familial short stature, we need to follow up the same. And sir, on following up this child over the next 6 months, we found that she has grown, and her growth is 3.5 centimeter over the next 6 months.
Yes.
Kindly
So this is a good thing that 3.5 centimeter in 6 months, and that growth velocity inculcate 7 centimeter per year. And if I'm going to plot this 7 centimeter per year on 12 year, then we can see here that it is about 50th centile. So this girl is growing very well in terms of growth velocity. And now we can label very safely that this is a girl which is familial short stature. So she is growing as familial expectation. So what is the practice point is that we have to be very sure that correct height for parental expectation. Just don't plot on the single basis. So for this case, no workup if height is within target range, as we have seen in this case. Follow-up is really important in mild growth failure. That can be a pathological thing. Yes, so this is the thing that, so growth velocity really crucial, and we have to ideally see for say at least 6 months, and it will be prudent if you are having for 1 year.
So thank you, sir, for taking us through this case. And the most important point which we take off from here is that even if a child is labeled or thought of to be of a familial short stature, she has to be followed up for her growth velocity and then labeled. Thank you, sir, for taking us through this case. And moving forward to the next case, we have this 13-year-old boy, again presenting to us with suspected deficiency in height gain with a height of 135 centimeter, weight doing fine. Again, her father's and mother's height is presented here. So Dr. Bipina, kindly take us through this case. Do you think the child is short?
Thank you, Sayan. Here we can see a 13-year-old boy with height 135 centimeter. Obviously, he's short for his age. And I would like to, as a first step, I would like the parameters plotted on a growth chart.
Yeah,
so
and
to calculate the height age, weightage, and the mid-parental height.
Yes, so the height age and weightage is around 9.5 years, and his mid-parental height also I have plotted here.
Okay, the mid-parental height is 169 centimeter with a range of 161 to 177 centimeter.
Yes.
And the born age falls at 11 years.
Born age is 11 years.
Yes. Yes. And so this boy has a height below the target range, just below the target range. And as we can see, the testicular volume is also shown here. That is 3 ml, which is pre-pubertal. Since puberty and growth are closely associated, we have always to check the pubertal status for all children with growth failure, and also should be a part of routine growth monitoring after the age of 6 years annually. So since the weight is also affected, I would like to do all the screening tests to rule out the nutritional cause and the chronic illnesses.
Yeah. So on further assessment, we found out that all the screening investigations are normal in this case. And then on further working up, as the book mentions a lot of investigations for children with growth failure, I went ahead for a basal growth hormone and I found it was pretty low. But then without a stimulation, I couldn't label it. And I went ahead with the GH stimulation test and I found out it was suggestive of partial GH growth hormone deficiency. So kindly suggest to me the growth hormone dose that I should give to this child.
So here the basal growth hormone levels are actually unreliable because it has a pulsatile secretion with maximal secretion at night. So it should not be done as a part of screening. And here the growth hormone stimulation test has been done and shows a value of 6.2, which gives us a misdiagnosis actually of partial growth hormone deficiency. Misdiagnosis because it has not been done with a sex steroid priming because this boy is pre-pubertal. And for all boys more than 11 years and girls more than 10 years, sex steroid priming should be done if they are pre-pubertal.
Thank you. I missed this. I didn't do any priming in this child. So when I did priming in this child, it came out to be 15.2.
So now we know that after the sex steroid priming, which can be done with estrogen for both sexes, that is 17-beta estradiol can be given 2 milligram for 2 days. And after that, if we do the growth hormone stimulation test, which gives us a clear diagnosis, now the growth hormone is normal after stimulation with steroid priming.
So all screening investigations and growth hormone levels are normal in this child. So the next step?
So we need not give the growth hormone.
So we need to follow up this child, as
Yes,
Dr. Vijay just mentioned in the previous case. And on follow-up, we see that the child is doing well. And at 18 years, he reached the height of his parents. So any takeaway points?
So takeaway points were the born age and puberty are crucial for growth monitoring, and for all pre-pubertal children that is boys above 11 years and girls about 10 years, the sex steroid priming should also be done before coming to a diagnosis of growth hormone deficiency.
I think that's a very, very important point. 99 boys who come to you at this sort of a height, which is just below the growth chart, are usually CDGP. So you don't need to unnecessarily start working up on everybody. Only if you talk about congenital GHD, they will be very, very short. And acquired GHD may be there, but it's not very common. So how do we identify CDGP? What we have done is that we try to differentiate between those who had an endocrine pattern versus a constitutional delay. And what we found, a simple parameter, if you are short for your bone age, you have a pathological cause. If you are not short for the bone age, you are normal. So if we can use a height standard deviation score for bone age, which is more than -2, it is a constitutional delay of puberty and growth. And we will use this in a simplistic algorithm from there. So as Dr. Bipina said, bone age and puberty are crucial. Consider CDGP in this scenario. And you have to really look at the priming, which is often missed in that perspective. Now, Dr. Bipina talked about estrogen priming. What are the other options in this boy?
Testosterone priming can be done.
So we can give both giving estrogen. Yeah, Dr. Bipina. So yeah, your views on that?
So for both sexes, estrogen can be given. For boys, we can even give testosterone. For 5 to 7 days, it can be given before test.
So generally, it might be sometimes difficult to give estrogen to boys. So we generally give testosterone. It becomes more culturally acceptable in that scenario. But yes, because ultimately estrogen triggers the growth hormone secretion, both genders. So it is absolutely valid.
Thank you, sir. And thank you, Dr. Bipina, for taking us through the case. Moving forward to the next case. This is a 15-month-old girl now with a birth weight which was LGA for the child. Birth weight of 4 kilograms, MPH of 150. Now, she was having failure to thrive after birth and was diagnosed as a case of RTA. So, Dr. Anurag, do you think this is a case of RTA?
The growth is not that much affected as one would expect in the case of RTA. And in this baby, as we can see, the birth weight was also on the higher side, more than 97 percentile, and height, as you can see from the growth chart, is also above 97 percentile. And you can see that what is the expected parental height, mid-parental height?
Yes,
so
sir.
The parental height is on the lower side.
The range of 3rd percentile. So we can see that something has been causing the baby to be on the last side at the time of birth, and it is aheading the parental expectation by 2 years of age. So this is most probably not the RTA, but maybe some other cause like infant of diabetic mother, because of which it was a large size baby.
So actually, this is a very, very important message which Dr. Anurag gave, was that the size at birth actually is determined mainly via environment, while size at final height is determined mainly via genetics. And the switch between the two happens typically by around 2 years of age. So this child is large. Now, Sam, you have to tell me what was basically the parental expectation.
So was on the lower side, and he's catching up for that only, sir.
So this is the parental expectation on the 3rd centile. So this child was destined to be short, but was born large because the mother had diabetes. So now in this context, Dr. Anurag, do you think that this child required so much evaluation? Dr. Anurag? I think we have lost Dr. Anurag, but so this case clearly.
Can you hear me?
Yeah. Now we can hear you.
Yeah. So during first 2 years, we can expect some crossing of major lines in a child, and that comes up to the parental expectation only. So within first 2 years, we can. Hello.
Yes, sir.
Yeah, carry on. Yes. Yeah. So it is normal for the first 2 years to have a catch up or catch down growth. If it is in accordance to the parental expectation, you don't need to do any further evaluation. And if you see this base axis of -7, this is a very marginal thing. If you've done so many investigations, you will find it to be abnormal. So, Doctor, what are the message, Dr. Anurag, you would like to give?
Size at the birth is determined by the environment. That is, in the intrauterine environment, the baby was exposed to high sugar levels, so it was large size baby. And the adult height is expected is determined by the genetics. And this switch from occurs by 2 years of age. So crossing of the major lines in first 2 years of life is not to be considered abnormal, and no workup may be needed for this period.
Yeah, thank you, sir, for taking us through this case. This was the point which sir also said when introducing about growth failure. The child not growing at all, only between 2 to 18 years will need to be worked up. And if crossing cell tides between 2 years, but reaching as per the parental height, do not work up at all. Thank you, sir. Moving forward to the next case. This was a 10-year-old girl having short stature, but also underweight, was diagnosed as a case of growth hormone deficiency and referred to us. So, Dr. Riddhi, kindly take us to this case, having short stature as well as being underweight.
Okay, so Sayan, first I would like to see the growth chart of this boy.
Yeah, I have plotted the same for you.
Okay, so here we can clearly see that height age is 7 years and weight age is 5 years. So weight age, which is more affected as compared to the height age. So as we have discussed, it can be the nutritional cause of growth failure, and which all other parameters were used to diagnose her as a growth hormone deficiency.
Yeah,
so what all workup was done?
I'll tell you those. The hemoglobin was on the lower side. We did the TTG also, as we were suspecting a nutritional cause, but the TTG was normal. And then we went in for a karyotype, which was also normal. Here, the IGF-1 was low and the basal growth hormone was low. That is why we diagnosed the same as a case of growth hormone deficiency.
Okay, so here all the screening workup, though it is normal, but clinically child looks like nutritional cause of growth failure. So we have to rule out all other possibility of malnutrition or malabsorption first before doing the hormonal workup, because here weight age is more affected as compared to the height age. Sayan, do you think here most important investigation is missed?
The most important investigation, which are you speaking about, Dr. Riddhi?
So this is the bone age. So when we are encountering any case of growth failure, the three most important investigation, I would say, one is the detailed clinical examination in history. Second is the detailed interpretation of growth chart. And third is the bone age. So here bone age actually is missed in this case. And we should look at the bone age first before doing
the main problem of bone age is that most people don't know how to do bone ages. So can you give a quick guide, a 2-minute guide about how to assess bone age?
Yes. So actually bone age is routinely prescribed investigation in each and every patients of growth failure, but it is difficult to interpret, especially at the level of pediatrician and general physician. So before doing the bone age, we have to keep in mind some precautions that always talk to radiologist before prescribing the bone age prescription. Please take the full left hand X-ray. So always write the prescription type like X-ray left hand and wrist, including fingers. Don't cut the distal epiphysis or middle epiphysis, because whole hand X-ray is required for the exact calculation of bone age. Secondly, fingers should be spread apart. And third, exposure should be proper. That's so that we can assess the each and every parameters of the morphology of the small bones also. Now there are
the other thing, Riddhi, is that which bones to focus on.
So mainly we have to focus on the smaller bones, that is the epiphysis of the fingers and metacarpal bones and radius and ulna. Actually, old textbook and even I was using the method of calculating the number of carpal bones to assess the bone age in my residentship days, but that is the useless method, because there is the variable in appearance of the carpal bones, and that is useful only in first 2 to 3 years of life. After that, that method is not useful. So in first, girls have more advanced bone age as compared to the boys, and that is 2-year advancements because of the effect of estrogen. So in first 2 years, we can see that number of carpal bones can help us for the bone age. After 2 years, in toddler, 3 years in boys and 2 years in girls, number of smaller bones, that is the epiphysis in fingers and metacarpals and distal phalanges and middle phalanges, help us to calculate the bone age. And after that, 2 years to till pre-puberty, we have to see the exact morphology of the smaller bones, that is the size of epiphysis, whether one white line is visible, whether 2 white lines are visible, or whether capping has been started or not. And after the puberty, whether fusion is started or not, that help us to calculate the bone age. Still, this method, that is very, very rough method to calculate the bone age, and that is not helpful for the accurate assessment of the bone age. And there are other methods are also available, like Tanner-Whitehouse 3. There is mobile application available for Tanner-Whitehouse 3. Grulich-Pyle method. Also, Bone Expert is available. But all these methods are very cumbersome except Bone Expert. Bone Expert is easy. That is that gives us the report only in 2 minutes, but that is very costly. That is not feasible at each and every center. And Tanner-Whitehouse 3 is very cumbersome method that is difficult to apply in routine busy pediatric practice. It takes around 10 to 15 minutes in unexperienced head. And Grulich-Pyle method is also not the ideal method to do at the pediatrician level. So we have been trying to develop the easy method for bone age assessment, and we have come up with this mobile application where we have to select morphological feature of only 5 bones, that is the middle and proximal phalangeal epiphysis of middle finger, proximal phalangeal epiphysis of thumb, radius, and ulna. With only these 5 bones, we have been able to calculate as precise and as accurate bone age as Tanner-Whitehouse 3. So this is very good method. It takes around only 2 to 5 minutes, and we have validated this method, and that has been accepted for oral paper presentation at national and international conferences. So
congratulations, Riddhi was part of the team which developed the mobile applications. We'd like to congratulate Riddhi for this. And this is easily available, and you can get the bone age done. So bone age, as you Riddhi said, is the most important thing, but unfortunately not done in that perspective. So now we'll go forward on the case. What do you think was wrong in terms of the growth hormone assessment was done, Riddhi, in this case?
Yes, so here in this case, the girl is diagnosed with the growth hormone deficiency on the basis of two parameters. One is the IGF-1, that is the actually screening test for growth hormone deficiency. But as we can say that growth hormone, IGF-1 is group screening parameter for diagnosis growth hormone deficiency, but it has some limitations. It is age-dependent parameter. This study has clearly shown that less than 6 years of age, it has no role in diagnosing growth hormone deficiency or screening growth hormone deficiency. Plus, it has effect of nutrition also. So each those who have malnutrition, in India, malnutrition is the most prevalent cause of growth failure. So here IGF-1 is not the reliable marker to screen for growth hormone deficiency. And second one, growth hormone has pulsatile secretion. Also, it has diurnal variation. So it has to be done growth hormone stimulation test. There is no role of basal growth hormone to diagnose growth hormone therapy. So the two wrong criteria were used to diagnose growth hormone deficiency, and falsely C is labeled as growth hormone deficiency. So can we say that what was further workup done in this case, Sayan?
As you just mentioned, we should always go by the growth chart. And as you clearly mentioned that this was a nutritional pattern, we went ahead with the IgA levels in this child because the TTG was normal. And in this case, we found that the Ig was undetectable. So the next step was a duodenal biopsy, and it showed a villus atrophy. So what do you think, Dr. Riddhi? Dr. Riddhi?
So in this case, clearly, as Dr. Riddhi said, the diagnosis based upon IGF-1 is more unreliable because this is malnourished, and it is so that's why we have a falsely low IGF-1. So here, IgA should have been done ideally before we had done the evaluation. So IgA was undetectable, and therefore there was an improvement in growth. So the key messages here are that if your weight is less, so the most important thing to look at in a short child is actually the weight and not the height. If the weight is less, this indicates a nutritional pattern. If the height is more affected, it must suggest a endocrine pattern. And if you're suspecting celiac disease, maybe first go with TTG. But if TTG is negative and you have a high pretest probability, get a IgA level done. That is very important. And IGF-1, of course, is not, we are not big fans of IGF-1. It's not good in malnutrition, definitely, in that scenario. And if you want to waste money, you can burn it, but don't do a basal growth hormone. The only role of basal growth hormone, Cyan, is
GH insensitivity.
so if you are strongly suspecting growth hormone insensitivity, height standard deviation -5, triangular facies, they have got frontal bossing, sparse hair, then you can do a basal growth hormone. And if it's more than 5, you may think that this could be a insensitivity in that scenario. So we'll move forward to the next case, and
Moving forward to the next case, this is an 8-year-old boy. Again, short, again, weight is not that low, diagnosed as a case of celiac disease. So, Dr. Vijay, do you agree with this diagnosis just by the clinical parameters that, as Dr. Riddhi just mentioned?
No, definitely not, Dr. Shayan. I have to see again, we have to plot on the growth chart. And again, we have to interpret in, yes. So by this parameter, what I can see here, that what is the most affected parameter. And the most affected parameter is height is. That is, height is the most affected parameter. And then weight is to chronological age. So
Yes,
here,
so height is 3.8 in this case.
okay, so height is, and what about this weight is?
Weightage is around 5.9 years.
Yes, very right. So go ahead, please. So we have to see the cause that here the most affected parameter is height is. So
Yes.
I would like to see the bone is as well as these interpretation that what is the bone is in this child. And then we have to see that whether the weight age is preserved mostly. So if
it was significantly delayed, Dr. Vijay.
yes,
And the diagnosis of celiac was based only on TTG levels rather than on actually a biopsy.
no, definitely. So here I want to add that please don't be misguided. So there is clear-cut SPGN guidelines that how to go about these things. So we have to really weigh upon whether what is the cause, whether the nutritional versus endocrine. So if the most affected parameter is weight age, then of course it is nutritional. If the most affected parameter is the height and the weight age is relatively preserved, it means that we are going to deal a cause for mostly endocrinal. So this is really important that a plumpy child, plumpy short child is, we are dealing with the endocrinal issue. Contrary to that, thin child, that is malnourished child with stunting, probably we are going to deal with nutritional, either less nutrition or malabsorption. So we have to really weigh upon these things.
So Dr. Vijay, there is a big confusion about celiac disease. When I had come, nobody used to believe that celiac disease is common in this part of the world. And now everybody thinks everybody is celiac disease. So
Yes.
what are the specific guidelines you like to follow? So this case, clearly, as you discussed, we did a biopsy and it was normal. Growth hormone stimulation showed a growth hormone deficiency, which is quite expected because
Yes.
this looked like an endocrine pattern. And MRI showed a hypoplastic pituitary. So this was a classical case. But I think what we want you is to focus on what will be your guidelines as far as the SPGN and other suggestions with regards to how do we evaluate a child with suspected celiac.
Yes. So if I'm going to see this SPGN guideline, so it is clearly shown that mere positivity on this basis, you can't label as a celiac. So if TTG IgA based is negative and we have to take the account of IgA. If IgA is normal, so then you can safely rule out that there is no celiac disease. But if there is IgA deficiency and your test is dependent on that, so there can be false negative celiac can be there. And it is always better to refer these children to the gastroenterologist part. If there is borderline increase, that is, if TTG IgA is increased by 1 to 10 times in range, then before labeling this diagnosis of celiac, it is always mandatory to have biopsy. And even in biopsy, what we are going to see the tissue diagnosis, that what is the label of mass grading, that is blunting of villi and so many things. So if mass grade 0 or 1 is there, we can safely rule out that celiac disease. So there is no need to have gluten-free diet in this. If Mars 2 or Mars 3 grade is there, then probably tissue has been affected and the child is going to have malabsorption. So it is prudent to manage as a case of celiac disease. And if TTG IgA is beyond 10 times, then we have to see the EMA antibodies. If it is negative, biopsy, and if it is positive, there, since it is very high antibody titer and this EMA is positive, so 2 positive antibodies. So we can avoid in this case a biopsy, and we can manage a whole case like a celiac disorder.
So if we just look at these 2 cases which we discussed, which caused a diagnostic dilemma, the first one was TTG was negative. The child had a high index of suspicion, so IgA should have been done in that scenario. The second scenario was TTG was 1 to 10 times the upper limit. So here the biopsy should have been done. So both the cases could have been evaluated in that regard.
Yes.
So Dr. Vijay, so now this is a big issue, that whether it is nutritional or endocrine. So what we did in part of our evaluation is whether we can use a specific criteria. So we talked about CTGP. We also looked into nutritional and endocrine. What we found is that if your BMI standard deviation score is below minus 1.5, it suggests a nutritional pattern. But celiac can happen even if somebody's BMI is not low. So while it is good that we are talking generally that, okay, if you are short and lean, then you think of celiac, but you can sometimes have short and normal weight also who can have celiac. So you need to be aware about that. That's why TTG has to be done in every other case. Another scenario is inflammatory bowel disease. So if you are 10 years and above and short and nutritional pattern, you should do a IBD workup. And which test will you do, Sayan?
It's a fecal calprotectin.
So we can do it fecal calprotectin for that in that perspective. So Dr. Vijay, your practice points from this?
Yeah, definitely. So think endocrinal cause in short and plump child. So nutshell, chota or mota bacha, then we have to see for endocrinal problems. Biopsy is mandatory to diagnose celiac. So please don't label celiac disease and don't start diet therapy just on the basis of antibody parameter.
So next case, Sayan?
Yeah. Moving forward to the next case. This is a 6-year-old boy. Now very short and underweight. Diagnosed as a case of nutritional rickets. Now you can all see the picture. This is rickets clinically. Now what happened is that even with a label of nutritional rickets, on multiple doses of vitamin D, did not recover. X-ray still suggestive of rickets. Now when you see the blood parameters, the ALP comes out to be normal. Along with that, we have a low potassium. Now I can't explain these findings. So Dr. Bipina, can you just explain these findings to me? Rickets not improving on multiple vitamin D courses and having a normal ALP with a low potassium.
Okay, this child has already diagnosed as nutritional rickets, not responding to multiple doses of vitamin D. And we can see that the calcium, phosphorus, alkaline phosphates are all normal with the low potassium. So we have to think of other causes of rickets like renal tubular acidosis, chronic kidney disease and all. And we have to rule out this. So I'll order a blood gas here.
Yeah, so on the blood gas, these are the findings.
Hello.
Okay, we can see that here there is metabolic acidosis and the anion gap.
Urine anion gap was positive. Yeah.
Okay, this is the normal anion gap metabolic acidosis, which suggests renal tubular acidosis. And the urine pH, can I know
urine
the difference?
pH was 6.8.
Okay, here the urine pH is more than 5.3. And on the ultrasound, we can see nephrocalcinosis also. So this is a clear-cut case of distal renal tubular acidosis.
Yeah, so this was the diagnosis that we missed, and we labeled the child as nutritional rickets when actually we had to think of other causes of rickets on having the child on multiple courses of vitamin D not recovering and also having a normal ALP. So kindly take us to the practice points here, Dr. Bipina.
We have to think of renal tubular acidosis in all children with rickets and growth failure. And another message is that we also should confirm that the renal function tests are also normal. Yeah. Low potassium is an important clue for renal tubular acidosis. And blood gas and urine pH can help us in making the diagnosis.
So, Sayan, what are the causes of rickets and growth failure other than RTA?
So rickets and growth failure will be CKD.
Yeah, and
So I can remember only RTA and CKD in this
Celiac
case.
disease.
Okay,
So
celiac.
this is a very more common will be celiac disease actually. So you have to consider all the possibilities there. Carry forward.
Yeah. So summarizing all, just by plotting on the growth chart, we can find out familial short stature. We can definitely diagnose CDGP. And then even if the biochemical tests point to other causes, we can definitely differentiate nutritional and endocrine causes and work up on the basis, just on the basis of a growth chart. So this is the message we are giving, that growth chart anthropometry is the primary thing that we need to do in all these cases. Moving forward to the next case. This is a 14-year-old girl with a height of 120 centimeter and a weight of 32 kgs. Now, this is the picture of the girl. She had a normal screening parameters, had a normal TTG. So, Dr. Anurag, what do you think is happening with the child? She's very short.
This is a girl who is very short, so we should always keep a possibility of Turner syndrome in all the short girls. And in this case, we can see the clinical pointers towards the Turner, that is the web neck, the widening of nipples, and the brachymetacarpia is also there. So this is definitely a case of Turner syndrome. And
So we went ahead with the FSH, which was 72.
Yeah. So FSH is higher, so that also points toward the Turner syndrome. But in all these cases, we should always go for the karyotyping. So we have to look for the Y cell line if there is any mosaic pattern.
Yeah, this was the most important thing, and this will also come up during puberty. That why do we need to do a karyotype even if we are confirmed that this is a case of Turner syndrome? So, what are the practice points in this case, Dr. Anurag?
If the Y cell line is there, then these will be associated with gonadoblastoma. So we need to do gonadectomy in these cases. So the practice points are consider the Turner syndrome, all the short girls, and karyotype is mandatory even with high FSH. And we should screen for associated defects like cardiac defects or the hearing problems, and growth hormone is needed, therapy is needed in all these girls, and there is no need to go for growth hormone stimulation test before starting the treatment.
So we have talked about three important pathological causes: celiac disease, Turner syndrome, and RTA. Now let's put it, when do we need to evaluate? I would say celiac disease evaluation is required for everybody who has growth failure, because we have even seen if your weight is normal, you may have celiac disease. What about renal tubular acidosis? The general message is that if somebody is less than 3 years, you should definitely do a blood gas. Beyond 3 years, if you have polyuria, if you have rickets, if you have other features, then you assess. Now, karyotype, of course, you should do in all girls, but after you have done all the evaluation. You don't want to do somebody as celiac, you go and then you do a Turner evaluation in that perspective. So if you have checked everything, then think of Turner syndrome. But another message is, often Turner is associated with other causes of growth failure. It could be celiac, it could be hypothyroidism. I have seen patients with hypothyroidism who are actually Turner who are missed out. So always be wary that if your height is disproportionately low, whether Turner is also there. So this is a very important message that Dr. Anurag gave in that regards.
Moving forward to the next case. Now we have a 5-year-old boy with a birth weight of 2.1 kg. His mother complains that he is growing poorly since birth, having normal development, but just look at his height and weight. Even for a 5-year-old, his height is 90 centimeters and has a weight of 10 kg. This is the growth chart that we have plotted. And Dr. Riddhi, kindly tell us, what can we do about this child?
So this is definitely SGA child, because his birth weight was only 2.1 kg, so small for gestational age child, and current age is 5 years. Still the child is growing below the 3rd centile. So this child definitely need growth hormone therapy, because SGA, which is not growing properly even after 4 years of age, need growth hormone for the height increment, for anthropological improvement. So growth in SGA, actually there are two groups of individual. One who bone is low, then their growth remains slow throughout the years of toddler and childhood, and even they remain short during the puberty, but they have chances of early puberty, they have chances of precocious puberty. So they have their final height remains short as compared to the other individual, but they have no metabolic complication, they remain healthy. While in other group of individuals where the birth weight is low, but they show rapid catch up and their growth is rapidly advancing throughout the years of childhood and puberty, and they tend to show the weight gain, even obesity during the prepubertal and pubertal years. Their puberty remains at the normal age, but they have they have higher chances of development of metabolic complications like type 2 diabetes, hypertension, and dyslipidemia, non-alcoholic steatohepatitis. So in SGA, we have to carefully follow the growth chart. Okay, so if the child is rapidly growing, we have to counsel them for the metabolic complications, and they can through the metabolic complication, we have to give counsel for the dietary restriction and even physical activity. And those who are not growing properly, they need growth hormone therapy after 4 years of age, even they remain their growth remain below 3rd centile. So in this study, it is clearly shown that percentage of children that remain below 3rd centile, they tend to grow below 3rd centile, that remains static after the 4 years of age. So even at 8 years of age, 10% of children will not grow further and they need growth hormone therapy. So maximum catch-up occurs by 2 to 4 years of age. So practice points in this case are: monitor the growth in SGA child. They can have a rapid growth or they can have slow growth. Wait for catch-up growth only up to 4 years of age. There are 2 guidelines, but we can maximally wait up to 4 years of age. Even after 4 years of they are not growing, growth hormone therapy is advisable. Assess for the other treatable causes of the growth failure like nutritional causes and celiac disease and other malnutrition. And there is no need for growth hormone stimulation test. You can directly start growth hormone therapy based on the growth chart and the birth weight parameters.
So very important message, 2.5% of all children are SGA. But if you talk about adult tall stature, 20 to 25% are SGA. So if you have a SGA child, he has 10 times the chance of developing short stature as an adult as compared to the other age group. So if you want to prevent adult short stature, SGA is a very important group to identify early and treat also in that regards.
Thank you, sir. Thank you, Dr. Riddhi. Moving forward to the next case. This is the 10-year-old girl. Again, very short. Weight is 24 kgs. Now, in this case, we have all the normal screening tests. TTG was also found to be normal. And Dr. Vijay, then after all the screening tests, now should we move ahead with the karyotype in this case, as this child is a girl? Dr. Vijay?
Definitely. First, we have to see that in picture, what I can appreciate that this is a 10-year-old girl, and definitely she is having pathological short stature. But there are many more pointers along with this short stature that I would like to see the correct anthropometry in terms of what is the upper and lower segment, what is the ratio of upper to lower segment. Yes, so definitely. Yes. So you can see that upper segment is quite more in comparison to lower segment. For this age, what we expect that it is going to be 1:1. And here again, infantile parameters are there, that is upper to lower segments are skewed. So this is probably maybe a case of skeletal dysplasia, and here not karyotype, rather I would like to see the genetic studies for presence of mutation, and that is FGFR and other things.
So the mutation showed FGFR, as you said, sir?
Yes. So what went, so whether this is positive for that mutation?
Yes, sir, positive for that mutation. And also thank you, sir, for correcting me again, that again, without performing the basics of growth chart and anthropometry, I thought of the investigations first. So again, thank you, sir. Yeah.
So the learning point is that we have to see the body proportion is important. So detailed clinical history as well as detailed examination, we don't forget, we never forget. And so this was a case of hypochondroplasia resembles rickets. So it is really very important to do all the parameters, and no need for extensive testing. Again, we have to look back that at what age the child was having this insult. So probably she was having short stature since beginning or very early in the life. So there are so many things what we have to take, and not only the karyotype, but genetic testing for prenatal diagnosis, because the parents are going to ask, yes, what about next child? So it is really important for that child and for the next progeny.
Thank you, sir. Thank you for your wonderful message. Moving forward to the next case.
So now we've discussed about various cases. Now we'll just try to use those cases as a concept to build up the algorithm for evaluation. So the first question is the child short? We look at height SDS. If height SDS is above -2, follow up. There is no need for urgent evaluation. If the child is short, my next question is the child short for the family? So you use the corrected height standard deviation score. If it is above 1.5, then you don't need to do it. Is familial short stature, follow. Now the child is short for the population, short for the family. The next question is he short for the bone age? Here, if it is above -2 standard deviation, the height standard deviation for bone age, this is CDGP. So these three will actually be 80 to 90% of what the pediatricians will see. You do not need a lot of evaluation there. But if the child belongs to the other things, you do a screening. And this we will include all workup like CBC, ALT, creatinine, TTG becomes important. Thyroid, of course, and blood gas before 3 years of age. Now, if all these are normal, you follow up. Or if your child is very, very short right at the beginning, or they are not growing, so in that scenario, you look at systemic features, you look for syndromic association, upper segment, lower segment, facies. If that is normal, do a IgA, because now you don't want to miss celiac and a karyotype in girls. You are saving a lot of investigation. You are not doing unnecessary investigation at this point of time. And then if it is normal, then go for growth hormone stimulation. So do not rush with growth hormone. It should be a very last. From our study, probably you will need in an endocrine clinic also, around only 20% will require a growth hormone stimulation. A pediatrician will be like 5% also. So don't rush with growth hormone. And then you diagnose GHD. We don't believe a lot in IGF-1. Only if you're thinking of insensitivity, IGF-1 will help. And then you can classify from there. So the three key parameters are height standard deviation score, corrected height standard deviation score, and height standard deviation score for bone age. These three will give you a real picture and you will be able to evaluate. Now, how do we use all this algorithm in our busy clinical practice? So what we have done, and this is Riddhi was the primary author in this, that we developed and validated our mobile application growth interpreter, which basically provides, based upon key inputs, you will know what is the most likely diagnosis based upon all the parameters I talked about. You don't need to calculate them, it will give it automatically. And what we found that there was approximately 99% concordance in what the app said and what our actual clinical diagnosis was. So we have developed this tool which you can use easily, which will help you guide in terms of evaluation and management. This will of course not replace clinical judgment, but will help out in managing in that perspective. Now we move towards the other side, Sayan.
So now moving forward from growth to obesity. Obesity is a very common thing that we face, all face in our pediatric practice. Out of the total patients that we have, they come to around 5%. But the most important thing is that the most common cause of obesity for today is physiological. The disorders account for only 2% of the cases, and we'll tell you how to distinguish between physiological and pathological causes of the same. So careful assessment is required, and the physiological obesity you can differentiate based on normal growth, normal development, and normal puberty. These are the three things that you will get in physiological causes. In pathological causes, they will be early onset, will have hyperphagia, and will also have other associations like vision abnormalities and all the likes. And they can also have other associations with other medications causing obesity for the same. In endocrine causes of obesity, you will have a short and plump child, if you remember what Dr. Vijay said. Yeah.
So most important when you want to evaluate, this is our algorithm for obesity before we go ahead with cases. First, look at the obesity criteria. If the child is not fitting, no worries. If the child is fitting and he is less than 5 years. Now, this is a criteria for genetic obesity. Less than 5 years, very obese. You would need a genetic study. Less than 5 years, less than +3 standard deviation score, or somebody who is above 5 years, look for syndromic features. development, vision, and dysmorphism. Normal growth, normal puberty, normal development, unlikely to be a genetic cause, don't need an evaluation. But if you have syndromic features, you need to do a genetic testing. And this could include evaluation for Prader-Willi syndrome first, because that's a methylation study, and then go forward towards a targeted panel. But this will be less than 1% of all of your children. So less than 1% will have a genetic or a pathological cause. The other thing, you look at height. If your height is compromised, do an endocrine workup. And otherwise, if it's more, you look for a complication screening. Now we'll start with the cases, science.
So moving forward to the cases, this is a 12-year-old boy who presented to us with obesity, had a height of 160 centimeter, had a weight of 70 kilograms. Now had a TSH on workup, it was found. He had a TSH of 7.91. Now was advised thyroxine. The child came to us and wanted to know the dose of thyroxine that we would prescribe him. So Dr. Vipina, what is the dose of thyroxine that we would prescribe in this case?
So this is a 12-year-old boy with the height and weight as shown here. Can I see his growth chart?
Yeah, this is the growth chart.
Okay, so as we can clearly see, this is an obese tall child. So usually hypothyroidism causes an obese short child. So here we should not be thinking of this subclinical hypothyroidism, or FT4 should be normal and mildly elevated TSH is the effect of obesity and not the cause of obesity, because in obesity the leptin will be increased and this will stimulate the TRH and cause a mild slight increase in TSH also. And this TSH will come down with weight reduction. Treatment is required only if the TSH is more than 10 or between 6 to 10 with features like goiter or anti-TPO antibody positive.
Yeah, thank you for this very important message, because this is a problem that we very commonly find. Obese child having a borderline TSH which is raised and given thyroxine. So the wonderful message that Dr. Vipina gave us, in these cases, we should not start treatment.
So subclinical hypothyroidism is present in around 40% of children who have hypothyroidism. This is from our study which Riddhi had done. And what we found interestingly is that if somebody has subclinical hypothyroidism, they have a higher chance of steatohepatitis. But we do not recommend that you start treating everybody. Look at TPO, look at goiter, look at family history. We'll talk more about when we talk about thyroid in the next session. But if your TPO is negative, TSH is less than 10, no need for treatment in that regards. So I think this is the last case, Dr. Sayan, 12-year-old girl.
Yeah, this is a 12-year-old girl with a height of 130 centimeter, weight of 58 kgs. So not that tall, but a weight which is on the higher side. But all the screening tests which were done were normal, and the child was reassured and sent back home. Now, this child presents to us now with rapid weight gain. So, Dr. Anurag, do you think that the child, the referring doctor missed anything when the child actually presented to him?
Can you show me the growth chart in this?
Yeah, this is the growth chart.
As you can clearly see the growth chart, this is a short and plump child. So we should work out for the endocrine and causes in this child.
The endocrine, the investigations which were done on referral showed a slightly low TSH with a normal FT4.
This thyroid profile is probably normal. So most probably this is a case of Cushing syndrome. We should do look for Cushing syndrome in all these short and plump child also.
This is the picture of the child, sir, when she presented to us.
The clinical picture is also suggestive of the Cushing syndrome. So we should go for overnight DEXA suppression test in this child.
So, sir, overnight dexamethasone suppression test was done, and it came out to be 154 nanomoles per liter.
So this is not suppressed, and so this is a case of Cushing syndrome.
Yes, sir. So, thank you for this wonderful message. A short and plump child needs to have a workup for endocrine causes of the same. And when clinical features match, we should go according to the clinical features. The TSH.
So I think this is the last case. Now, Riddhi, this is a higher child who is 3-year-old with rapid weight gain. Weight is 26 kilograms. And there is severe hyperphagia which was present since birth. What do you think we should be doing here, Dr. Riddhi? The basic workup is normal.
Yes. So here in this case, actually the girl is less than 5 years of age. So early onset obesity. Plus there is one marker that height is also on the lower side. There is rapid weight gain and severe hyperphagia. All these pointers suggest towards a pathological cause of obesity. So we should definitely do genetic study or other parameters like leptin level, because leptin, which is most important hormone required for the satiety of the
And one big
satiety of the food.
message here is that there are recurrent infections which are common in leptin deficiency. So
Leptin deficiency.
yeah, we got leptin levels which were undetectable.
Detectable. So
And
this
this
is
was
the proven case of leptin deficiency.
So we need to be very cautious. If there is an early onset obesity, then think of genetics. So again, the big message is that in obesity, you don't need to evaluate everybody for a cause. But if they are short, early onset, there is hyperphagia, syndromic features, delayed development, vision abnormalities, you need a workup from that perspective that we found. So we have also developed a obesity interpreter, which basically uses these parameters, just simple parameters. All you have to do is to plot them and you will get what is the likely diagnosis. We have validated this, and what we found, and this is from our own clinic. So what we see, even in a pediatric endocrine clinic, 92% obesity is physiological. So if you talk about pediatrician, it will be like 98%. 7% had pathological endocrine cause and only 1% had a genetic cause. So this is from our own clinic. So this is a referral center we are seeing this. And when we found, again, only one case had a discordance. So this app can really guide. Like this case, it guided that this could be Bardet beetle because the vision was abnormal. So it has specific inputs which uses those algorithms to make a diagnosis from that regard. So the practice points is obesity is usually constitutional. Height is the most important. In a boy with short stature, weight is most important. In an obese child, the most important thing to look at is the height. Do not treat mild elevation of TSH, and short and plump is endocrine. Dr. Syed Farooq Ali is asking about what is the cause of polyuria in Rickets. Now, this child had polyuria. It was not because of Rickets, but this was a renal tubular acidosis. So if you have polyuria along with Rickets, think of RTA as a possibility. Dr. Bharani Anand is asking, sir, in case 7 Turner syndrome, there were clinical pointers to syndrome. Should we use Turner specific growth chart or normal growth chart? Now, this is a very important thing. Why we should use the Turner specific growth chart if you want to look at whether there is an additional cause of growth failure. In normal chart, Turner girls will be short. In Turner chart, they should be normal. But if you wait for them to get below Turner chart specific one, you will be too late. So the treatment recommendations are height, which is below the 5th percentile by the normal growth chart. And even the Cincinnati growth line, what they say is that if there's a high tendency of having short stature, you start treatment. You don't wait. So you look, actually you plot on a normal chart. Now, how much growth can be expected in Turner syndrome with growth hormone? Very relevant. When you treat with Turner syndrome, the expected response is not as good as GHD. You expect 1 centimeter per treatment year in terms of benefit, which is there in Turner syndrome, which is there in that scenario. Dr. Priya is asking when to start growth hormone therapy, when to stop growth hormone therapy. So growth hormone therapy, very importantly, should be given only when there are specific indications. There are 3 basic indications, I would say: growth hormone deficiency, SGA, Turner syndrome. Others are rarer, like Prader-Willi syndrome, Noonan syndrome, or idiopathic short stature. There are specific guidelines. You have to prove growth hormone deficiency. That is one. Second, Turner's or SGA you can treat. SGA, ideally, you can start after 4 years. The treatment should be continued till the height is there. So the bone age, if we have got reasonable bone age, you can use it till that perspective. So these were the specific questions. I think we'll also look at the practical scenario of growth hormone in familial short stature. So if there is a familial short stature that fits into idiopathic short stature, there what you need to understand is that the response to growth hormone is limited. You do not expect huge response, 3 to 5 centimeters at a very huge cost. So what I will suggest is give a course of growth hormone for 6 months. If the height is increasing, continue. If the height is not increasing in that scenario, you would need to probably stop therapy at that point of time.